The following program has been made possible by an educational grant from Bayer Healthcare Pharmaceuticals, Inc.
Welcome to the second show, MS from A to Z. I'm very proud of this series, which is a 9-part series on the disease multiple sclerosis. It is aimed to patients with MS, families, their loved ones, healthcare professionals, and others who want to learn about this disease. On the first show, we talked about, in general, what MS is, some new concepts about the disease. And in this show, we are going to talk about the history of the disease. We're very honored to have as the speaker on the history of multiple sclerosis the very distinguished Canadian medical historian, Dr. Jock Murray. Dr. Murray has been active as dean at Dalhousie School of Medicine in Halifax. He was the founder of the MS clinic there, of the MS research there. He has received a number of awards from a number of organizations throughout the United States, and not the least of which, he is a member of the Order of Canada. And I would like to point out that Dr. Murray has been given awards for his book on the history of MS, published by Demos, and I would encourage any of you who want to learn more about it to obtain his book. Jock, welcome to Seattle. Thank you for coming.
George. It's a great pleasure to be here.
Across the continent.
Well, George and I have been colleagues for many years and share an interest not only in the care of multiple sclerosis patients, but an interest in learning more about this disease. One might wonder why I've been asked to talk about the history of a disease, because why would we want to look back at previous centuries to see why people understood and knew things that we now perhaps find outdated? Well, there is a good reason, because the understanding of any disease is on a continuous timeline that increases. Diseases are ideas, and they change over time. And over the course of centuries, we've learned more and more about the disorder. And I think we can see that we're continuing every week to know more about this disease. So I'd like to give an overview of what we've understood over many centuries. Now, what you think of a disease, whether the disease is multiple sclerosis or diabetes or heart disease, there is a changing concept. So it's not just an entity, it changes in the course of time. What they understood in 1900 about diabetes changed by 1950, and it changes every year now. So the concept of the idea of diabetes continues to change, and that has also happened about multiple sclerosis over the centuries. So what you think about its biology, what its cause might be, the treatment, the response to treatment, what the relationship is with other people, what the genetics of the disease, it continually changes. So a disease is not a fixed thing in time, it continually changes. And we frame many things in different ways. And I'd like to look back when they framed this disease before it even had a name. We know that in previous centuries, in the 16th and the 17th centuries, people recognized there was a disease that affected young people, caused difficulty with their mobility and other symptoms, but they didn't have a name for it. And the first one that we can identify is a saint in 1400 in Scheiden in Holland. And this saint, whose name was Lidwina of Scheiden, she was on the canal skating when she fell and realized that she had trouble with her balance. That was her first symptom that something was wrong. Now, over the course of the next 20 or more years, she had a progressive disease that we would now identify as multiple sclerosis. But at the time, there was no name for such a disease. And the understanding of this was that it probably was not treatable. And she was consulted by many of the prominent physicians of the day, including royal physicians. And one of them, a very prominent king, a physician to the king, identified this as a disease that was not treatable, was caused by the hand of God, and it would just impoverish her father to continue to try and find and use new treatments and expensive ways to try and alter the disease. So she's the first one we can probably identify, and that was in 1400. The next one that we can identify quite clearly as having MS before the disease had a name was a young man, and his interesting background is that he was the grandson of George III. His name was Augustus d'Este. And when he was in his early 20s, he came from a funeral, and he noticed that his vision suddenly went in one eye. He thought it was from trying to suppress tears at the funeral. But the interesting thing is that day he began to keep a diary. And on that first page of the diary, he describes the loss of vision. And then over the course of the next 20 or more years, he recorded his illness. And so we have a very clear record, not only of his symptoms and his progression with the disease, but what his doctors thought, what the treatments were used, and the course of his disease, which occurred in the early 18th century. A remarkable record, and there is no question now, with the amount of documentation, that he clearly did have multiple sclerosis. And there are other cases that we can now identify. We can identify this in a Victorian writer, a person who ran a Hudson Bay company. And we get these things from records and diaries and records at the time. Now, at this time, there was no definite diagnosis of multiple sclerosis, and all of these cases were called paraplegia. And paraplegia was a general category for anyone who had difficulty with mobility in their legs. Now, we now know that a lot of other neurological conditions would also be put into this category, but all the patients with multiple sclerosis would as well. When things began to change in the understanding of this disease was in the early 1800s, when pathology was becoming a very prominent aspect of medicine. Diseases could be understood by doing autopsies on patients and learning more about the pathology that produced the disease. Now, the people at the time who were really good at this and good at classifying different kinds of disease were the French. And the French began to look carefully at a lot of these diseases. This was also occurring in other countries, of course, but the French in particular were classifying neurological disease at the time. And one of the most prominent in this was Charcot. And it is with Charcot that we identify the discovery of the disease. And that's because he gave it a name, and he indicated what the characteristics of the disease were. But before Charcot, there are at least 13 individuals who knew about this disease and wrote about it, published it. And so they could identify the disorder. And the reason it's identified with Charcot was that the individuals before that didn't give it a name. And so when he gave it a name, other people could now recognize it. So we had Theodor von Friedrich. He was an individual before Charcot who not only knew the characteristics and the pathology of the disease, but he was the only one who could actually diagnose it in a patient in life. Now you wonder, why didn't we name the disease after him? Well, people weren't very convinced at the time. It took Charcot in 1868 in 3 lectures on the disease to say, these are the clinical characteristics, this is the pathology, this is the course of the disease, this is the response to therapy, and this is the name of the disease. Now, he didn't, of course, use the word multiple sclerosis, but the terms changed over the course of time, but he now gave it a name and showed the characteristics, and everybody around the world could now identify this particular disease. So after 1868, when Charcot made his famous lectures, we suddenly got reports from the United States, from Germany, from Austria, from Australia, from Canada, because everybody could now recognize what this disorder was. Now, a number of things were coming together at the time of Charcot. We tend to think of events occurring in medicine in which someone suddenly comes out of the laboratory screaming eureka, but actually it often involves a lot of people, a lot of steps that occur before, and with Charcot it was the same thing. A number of the features were, the French Revolution took the professors out of the universities and in the academic centers and put them into the hospitals. And so they had large numbers of patients and big clinics. The second thing was the interest in classification at the time. And so Charcot and his colleagues were very good at taking all these patients they were seeing and classifying the different diseases. He also involved a method called the clinical pathological method. We take it for granted. But he followed patients with long records over many years, and when they died, the autopsy would show the pathology. He would then correlate that with the symptoms they had for so long. And when he had a group of these, he would not then describe a new disease. And the description then of multiple sclerosis came from his collection of patients who looked the same and had the same pathology. The same occurred with amyotrophic lateral sclerosis, or ALS, which he first described by, again, getting a group of patients. There were other things occurring at the time. The use of the microscope was increasingly used in pathology and by clinicians, and Charcot was very good at it. And because the only way to identify for others what you saw in the microscope was to draw it, Charcot happened to be a very talented artist. And so he was very effective at drawing what he saw when he looked at patients with multiple sclerosis. The famous picture of Charcot teaching in one of his Tuesday clinics shows that people came from all over the world to work with this man and learned his approach to neurology and teaching. And many of those went on to make great contributions in the area of multiple sclerosis. His 3 lectures were given in his Friday discussions. He wasn't actually a very good speaker, but what he could do is make this a very powerful theatrical event. So he actually had a stage with footlights and a lot of audiovisual phenomena to make his lectures much more interesting. And he spent the whole week memorizing his notes so he could then make his lectures without notes, looking like he was very spontaneous. So he had a method which was inspirational to others, and people came from all over the world to learn neurology from Charcot and his colleagues, and these large clinics where they could get a lot of hands-on experience with large numbers of neurological patients. Now we can look at his drawings of the brain and of the microscopic appearance in multiple sclerosis and see what he saw. Now the interesting thing now is that we're finding in recent years some aspects of the pathology of multiple sclerosis, and we're looking back at Charcot's drawings because we can actually see these apparently modern discoveries in his drawings. Now it could have been described and perhaps related to a neurologist in the United States at the time, because S. Weir Mitchell, who was regarded as the American founder of neurology here, actually described a case in the same year as Charcot. The problem was he didn't give it a name, and he didn't discuss it in any great detail, and so it's not identified really with him. The Surgeon General at the time was also a very effective neurologist and wrote the first American textbook of neurology, and in that he has 9 cases of what he identifies as being multiple sclerosis, but he refers to Charcot because he knew what Charcot had written. In England at the time, they were beginning to identify cases now that Charcot had made it clear, and they were beginning to recognize this disorder and publish its response to different therapies. Now, William Moxham, who was the first one to describe it in the English literature, had a long list of therapies, but unfortunately, he felt these were not very effective. In Canada, Sir William Osler described the first 3 cases in that country, and he did it in a way that he said he wished life was like that, because he was sitting reading in a journal the description of multiple sclerosis. And when his assistant said that the next patient was ready, the patient came in, sat down, and described everything he had just read in his journal, and he said he wished life was like that. But he could clearly make a diagnosis in that example. Now, most medical students recognize the name Babinski because his name is associated with the famous reflex response of the toe going up in neurological disease when you scratch the bottom of a foot. And many of you may have had that phenomenon by your physician and wonder why they scratched the underside of your foot. That's called the Babinski reflex. Well, Babinski's thesis in Paris was on multiple sclerosis, and he was a student of Charcot, made great contributions at the time to the understanding of the pathology of the disease. Another of Charcot's students was Pierre Marie. Now, Pierre Marie was a very powerful individual at the time who knew and pounded tables over the fact that he knew the cause of this disease and he knew what the eventual cure would be, because he believed it was an infection. And because Pasteur and others were describing more and more vaccines against illness at the time, he was convinced that very shortly there would be a vaccine that would eliminate multiple sclerosis. Unfortunately, we haven't found a vaccine that will make it go away, but it is interesting that the question of an infection is still there in the disease, and there are people currently working on the possibility that there could be a vaccine in the illness. Even though the understanding of the disease progressed over these years, we're understanding more and more about its pathology, about what changes were occurring in patients, how to classify different kinds of patients and different responses in the disease. One thing that wasn't changing very much was the therapy. Now, we tend to think that therapy is relatively new in MS, but there was always therapy. People were always being treated for the disease. The question was, what efficacy did those treatments have? Many of them had no effect. Some of them gave some comfort, but others might have caused the patient more discomfort than they had before. And we know that came from the idea that perhaps if something worked in one neurological disease, it might work in another. And some of those, unfortunately, worked in diseases like neurosyphilis, which you gave patients heat therapy, made MS patients feel worse. But that phenomenon, and it still goes on, of identifying in one disease a therapy that works, why not try it in another disorder? So understanding of the disease changed over the course of time, but therapy actually didn't change very much. But we can see that in every age there was still a very long list of things that were used. Another advance in thinking about the disease that occurred in the early 1900s was made by Byram Bramwell, who was a prominent consultant in neurology in Scotland. And he didn't do this by doing a major world survey of the disease. He merely talked to his colleagues when he went to a meeting. And he noticed that when he was at an international meeting, if he talked to people from Scotland or from Norway or from New Orleans or from New York, that the number of cases of MS that they saw was different. And because of this, he spoke to people from different parts of the world and noticed it's odd that neurologists in different parts of the world were seeing different numbers of MS patients. And he was the first to suggest that there's actually a geographic distribution of this disease, and that in different parts of the world, the incidence of the disease was different. He also made the interesting suggestion that the lesions in multiple sclerosis look like the lichen on a wall or on a gravestone. And in fact, it's a little reflective of what we sometimes see on the modern MRI of these scattered white spots. Now, therapy didn't change very much, but one of the things that was important in 1921 was a growing consensus about what the disease was about. Now, we don't often give credit to a meeting. We give credit to great discoverers and the great discoveries in medicine, but sometimes a meeting changes the way people think. And the meeting in 1921 in New York was a meeting that was important because people came together who had an interest in multiple sclerosis and acquired a consensus of what the understanding of the pathology, of the therapy in the disease, of the course of the disease, a lot of aspects of the disease, and after that there was a more concise consensus about the disease and what it was about. Now, in 1930, there was a great deal of excitement because a very prominent London consultant in neurology published a paper in The Lancet indicating that he had discovered not only the cause of MS, but the cure. And there were two papers, one by him and the next one by his research assistant, Kathleen Chauvisot. And the first was an indication that they had found an agent called Spirula insularis, a viral particle. And the next article next to it was the vaccine that they had developed, and they had already treated a large number of patients, and many of them were showing benefit. Well, there was great excitement about that idea. Not only do we now know the cause, but we now have a cure. But there was skepticism about this and increasing very vocal arguments about this at meetings in which James Purvis Stewart was presenting the work. And at one meeting, he left the meeting, she left in tears, and they never presented this work again. And later it was shown that she, in fact, was concocting all of this by changing the lumbar puncture tubes from patients, and there actually was no identified agent, and the whole thing was actually a fraud. Now, James Purvis Stewart was a bit naive and innocent of all of that, but it did show that one has to be critical in their thinking when we analyze what may appear to be a cure in multiple sclerosis. Another difficult thing occurring during those early years of the 20th century was a recurrent idea that people struggled with, and that was, could you transmit this disease? And the reason that that was a struggle is from 1913 up until 1980, there were repeated reports that people had transmitted the disease. They could take spinal fluid from an MS patient, inject it into an animal, and the animal develops a MS-like disease. Or that it occurred from transferring brain tissue from an MS patient into an animal. Now, any lab that tried to reproduce what had just been reported failed. And so over and over, the reports were made and then discounted because no one could, in fact, duplicate it. But the odd thing is that it kept recurring over the century. And no one believes now that you can do that, but we're not sure why it was that it happened so often that people reported it. Another thing that was important, which gets very little credit, we talked about the meeting and how that could be important. No one gives much credit to a review, and that is a clinician who just writes a review of the current understanding of a disease. It's really just a summary of the current thought. But a young English neurologist by the name of Russell Brain, later Lord Brain, and how could you not be a neurologist if your name is Brain? Well, he decided that he would encapsulate the current thinking, but he had his own personal view on many of these things. But he also clarified what the disease was about, and he put aside many of the claims that were being made, particularly for therapies at the time, and felt that none of the current ones in the 1930s were in fact helpful. But other things began to change. A very important change that occurred in the 1950s was the formation of the Multiple Sclerosis Association. It was later changed to the National MS Society, but it was started by Sylvia Laurie. She had a brother with multiple sclerosis, and Bernard had difficulty getting information about what the disease was about and what therapies might be available. So the sister, Sylvia, put a simple ad in the New York Times. And it was, multiple sclerosis. Will anyone recovered from it please communicate with the patient? And gave a New York Times box number. Now she got so many responses that she concluded we should form an association. That association, the formation of the National MS Society, has been one of the most important factors in the development of progress in multiple sclerosis since then, because they support much of the research that goes on. They bring together the people who are interested in doing the work, and they foster the development of care for MS patients and an understanding of the disease through research. So Sylvia Laurie, with her energy and her vision, in fact, did one of the most important things, I think, in the progress of this disease. Now, it also came at an important time. She did this in the late 40s. And at that time, a couple of other things were beginning to develop that are important for multiple sclerosis. One was a sense that we need to more carefully classify the disease. And George Schumacher, a neurologist in the United States at the time, did a classification that everybody then accepted, that this is the way we will classify different MS patients. It has changed since then, but the idea was essentially that. We had the Poser criteria that later came in the 1980s, the late 90s, and since then we've had the McDonald criteria. But the idea is to classify very carefully the kinds of MS that occur and the kinds of patients who develop the disease. That's important in analyzing the response to therapy. Another thing that occurred at that time was the discovery of cortisone. So here we had a therapy that looked like it might be good in multiple sclerosis. Henry Miller, not the author, but the neurologist at Newcastle in England, decided to use a new idea that had just developed in the post-war period. That's the idea of the randomized clinical trial. And it was the first trial done in multiple sclerosis. 1960, he analyzed by a randomized clinical trial whether or not steroids had any effect in multiple sclerosis, in treating acute attacks of multiple sclerosis, and showed that it did. And that started the development that's been used since, that if you think you have something that works in MS, then there is an accepted way of analyzing how that happens. There is a tendency to feel that almost everything works in MS because it's a relapsing, remitting disease. People come to see the physician when they're feeling worse. If you're given a therapy, the natural history is that you will tend to improve. So it looks like the therapy worked. And physicians and patients want to see benefit, so there's a tendency to see it even if it isn't there. And so the randomized clinical trial tries to get rid of some of the confusing aspects and see if the therapy really has any benefit. And that methodology has developed and is very important now in clearly indicating whether something is effective or not, whether it's safe or not, and also the cost effectiveness and the cost benefit of any new therapy in multiple sclerosis. Now, over the course of the last 50 years, we've had a number of eras in therapy. When the antibiotics were discovered, we used almost every antibiotic that came out in treating multiple sclerosis because the idea was still there that infection has something to do with either the attacks or precipitating attacks of MS. And so any new antibiotic was always used in multiple sclerosis. When anticoagulants were developed, the idea that maybe there is a vascular aspect of the disease might be important. So anticoagulants were used from the late 1930s up until the 1960s in the disease. Then when cancer therapies were being developed, every cancer therapy that developed was being used in multiple sclerosis because we understood more about the immunological aspects of the disease. So it became more and more important that we had a method of testing a therapy by a randomized clinical trial to identify whether or not things were useful. Now, the difficulty with multiple sclerosis, unlike many other diseases, is that it has a natural tendency early on to relapse and remit. So to see whether something has a benefit, you really have to look over a very long period of time, and you need a very large number of patients to do the study. And as a result, they become very expensive. But it's still the only way that we could really judge this. Now, during that time, many therapies were in the media as having major impact in multiple sclerosis. And these included the Lagac therapy, which was an anti-rickettsial therapy, histamine desensitization for multiple sclerosis, forced CSF drainage, fever therapy, cervical dorsal sympathectomy, a major operation to see if it would help MS patients, ganglionectomy. There was the Stransky serum therapy. Psychotherapy was used with the understanding that stress was a major factor. The Alexander regime of steroid, which is a long-term therapy. On and on it went over the course of these years. Many of these, of course, came, they were a fad for a while and then disappeared. But it wasn't that there weren't therapies. things were always being tried. When things began to change in terms of our understanding of the disease was the coming of the MRI. And the first disease that really looked dramatic on the MRI was multiple sclerosis. And so the early publications of MRI are actually on MS. And we found that this was a dramatic way to demonstrate the presence of the disease and the changing nature of the disease. And one thing it did tell us is that this isn't as intermittent a disease as we thought. That if you did MRIs on people repeatedly, you saw that there was continuous activity, often without any symptoms, that things came and they went on the MRI. So it was teaching us not only how to diagnose better and confirm the clinical diagnosis, but it was telling us something about the nature of the disease. It was also widely used in the assessment of new therapies to see if it would alter the MRI. We began also to learn more about the genetics of the disease. We know that people with MS usually have a predisposition to the disease. Doesn't mean that everybody with the predisposition gets the disease, but there probably is some inherited aspect. And that's been shown by a number of very large genetic studies. The Canadian study, which has over 30,000 people in this study, has clearly shown that there is a genetic predisposition, but it's not enough just to have that. And we could show that, for instance, with identical twins, that if identical twins, one of them develops MS, 1/3 of the other twins will develop it, but 2/3 don't. So there has to be something other than the genetic connection, because those identical twins are genetically identical. Now it's interesting historically to reflect back, because that observation was actually made in the 19th century. But people kept dismissing it. They kept saying, well, it's probably a coincidence that there's an uncle and another in the family with MS. People kept noticing that there were more than one in families, but they kept discounting it. And that was discounted until it was convincingly demonstrated in the 1940s. And now we have some very large studies going on in the world looking at what the genetic factors may be. We know it's not a simple gene, as occurs in many diseases, but that it's a very complex genetic predisposition. So I mentioned that classification is important, and we currently have a classification that says that there are patients with a relapsing remitting form of the disease, and 85% of the new cases have that form. That there is a secondary progressive form, that many of those patients go on later to show some progression. That's later called secondary progressive disease. There's a type called primary progressive MS, and those are patients who don't have attacks and show just a slow progression. And there is a progressive relapsing. Those are patients, and these are not very common, who look like a progressive disease and then may have a relapse later. And there's a group of patients who have a benign form of the disease. And that means that for a very long period of time, they have relatively minor involvement with the disease. Now, what have we learned over that long course of history? Well, we've learned some things, and our understanding continually changes. As I mentioned, our frame for this disease is changing every year as we add new information and discard other ideas. But we now think there probably has to be a predisposed individual, that there's some trigger then that determines that that disease will manifest in the person, that there's some involvement of the blood-brain barrier and some damage occurring, that there is then an immunological reaction occurring in the brain that affects myelin, but it also later damages axons, and that's probably the factor that causes progression. So that kind of simplistic view of what goes on in the disease is the current understanding, but there's a lot to understand beyond that. We need to understand, why is it different in different parts of the world? And people wonder if that's because infections are different in different parts of the world. Vitamin D involvement is a current theory that people are looking at, whether it's the exposure to sunlight and vitamin D that may be a factor. And others wonder if it's just genetic drift. Is it the people who migrated to the parts of the world that have a lot of MS just tended to come from populations that had a high predisposition. Well, we'll know more about that, I think, in the future, but still we have a number of theories of why we have this worldwide distribution. So I think the main point is that if we look at history, what we see is the frame of multiple sclerosis from the time of Ludwina of Scheiden, when her physician thought this was just a disorder that was given to her by God, to paraplegia in the 18th century with Augustus d'Este, George III's grandson, in which it was just lumped as a form of progressive paraplegia, to the modern concept of a disease that has a characteristic and a name. And we see now that there is an immunological reaction occurring in the disease. We know there is some genetic predisposition. We now have changed from the fact that this is a demyelinating disease affecting myelin to recognizing that myelin is important, but the axon is probably as important in determining the outcome of the disease. We called it a white matter disease. We now know there's just as much involvement of the gray matter. And so that's a changing concept of the frame of this disorder. We used to think it was an intermittent disease. We now know that it's a much more constant and progressive one. We thought it was a focal disease. We now know it's much more widespread. And we used to think it was untreatable. And we now know it's a very treatable disease. And as we've seen over the last few decades, more and more effective therapies are altering the outcome in MS patients. So at the present time, we've come to a very hopeful stage in the disease, one that looks like we're going to advance year by year in the impact that we'll make in the disease and the outcome of MS patients. So there's a great promise for the future. We now have over 30 new agents that are under study. There are 9 oral medications that are under study, and many of those are pretty well through their therapies. We have combination studies of different medications. We have better symptomatic therapy for the disease. We have a lot of basic research that's telling us much more, and it's the basic research that guides us in so much of this. And we have better approaches to rehabilitation than we've ever had before. So it's a very hopeful stage in the disease, and that's one thing that changes as time goes on. But the last point I'd like to make is that we tend to think and discuss the disease as a biological phenomenon. But it's important to recognize that a person is more than their body and their biology. It was shown and discussed by Eric Cassell, the internist and ethicist in New York, who indicated that when you think of disease, it's more than just the biological process that goes on. A person, you and I, all have a personality and a character. We have a past. We have a cultural background. We have a number of roles that we play in our life. We have an existence with other people. We have a political process that we use to negotiate the way things change in our life. We have a body, but we also have a secret life. We have a perceived future, and we have a life of spirit. Now, a threat to any of those causes suffering. It's not just our body. And so in thinking about multiple sclerosis, we also have to recognize that it affects a person, and it affects a family, and it affects a community. And that as we advance in the understanding of this disease and its treatment, that we understand the implications of this for all of those aspects. It's a very hopeful time. Looking at the history of this disease, we've never been in such a hopeful time as we are now. And I'd like to refer just to a book that was written by a young man with MS in 1919. He wrote a book called The Journal of a Disappointed Man by W.N.P. Barbellion. It was a pen name he used, but he wrote a very moving account of his life with this disease. It's still in print. And he said at the end, it would be nice if a physician one of these days were to gallop up Hotspur, tether his horse to the gatepost, and dash in waving a reprieve, the discovery of a cure. Well, that will probably come, not by a physician rushing in, but by a series of very methodical steps by basic research, by clinical research, and advances in the understanding of the disease. But I think all of us now are recognizing that that is a justified hope and something that we will see in our lifetime. Thank you very much.
Thank you very much, Jock. That was superb.
My pleasure, George.
I really learned a lot, and I hope all of you learned too. But I have one more question for you, and that is, when was the first time that it was published in a medical journal? How long ago was that?
Well, they were beautiful illustrations done by two individuals. It's interesting, we don't know whether they ever met, but they were actually working at the same time in the Paris hospitals. And they were doing great atlases of disease, and they were doing, they're both magnificent artists. And both of them had in their atlases, the first one was a young Scottish medical student by the name of Carswell. And he has in his atlas a description and a drawing that clearly is multiple sclerosis. Now he just called it a very peculiar disease and had no other discussion about it. But Cruvellier, a Frenchman, in the same hospitals at the same time, was doing an atlas, and he has a number of cases in which he describes the clinical picture of the patient as well as the illustration. So that's the first time we saw it, and after that, the interest began to develop about what this disease was, and that culminated in Charcot finally naming the disease and describing it and saying, this is what this disease is.
Fantastic. Thank you again.
My pleasure.
Thank you again. I would like to thank you, the audience, for your attention. And I'd like to remind you that our third program in MS from A to Z will be on another topic. It will be on jobs and employment issues. People with MS can have some problems with employment, and we hope that this next program, the third program, will be helpful. It will be somewhat different than the previous two programs in that it will be to a live audience in a studio where there will be a series of questions and answers, questions from the audience and answers from the panel. So I look forward to coming back again as host of that show on employment and MS. Thank you.